All right, we'll start now. We have more than 100 participants joining us. Thank you for joining us today, and welcome to the webinar. Today's speaker is Professor Louise Newman, and she will be sharing her insights on building early attachment and resilience project, supporting vulnerable families. This webinar is a 30-minute presentation followed by 15 minutes of Q&A session hosted by our patron. Thank you, Professor Tonge, for joining us today, and we are delighted to have you on board.
Well, greetings and welcome to everyone from not just around Australia, but internationally as well. And I'd like to start this webinar by acknowledging the traditional owners of the many groups and lands within Australia and the Torres Strait Islanders, and acknowledge their elders past, present and emerging. It's my great pleasure today to introduce a wonderful friend and colleague who is in fact a leading international expert on the field of perinatal and infant mental health. And it is in fact one of the aims of the Mental Health Foundation Australia to promote mental health and also build resilience. And that's what Louise Newman, who is a perinatal and infant psychiatrist at the Albert Road Clinic and a professorial fellow in psychiatry at the University of Melbourne, and also of psychiatry at Newcastle University, who's going to address us. Welcome, Louise, and we look forward to hearing about building early attachment and resilience, the BEAR program in parents and infants.
Thank you very much, Bruce, for introducing me, and thank you so much for everyone being here today, taking time out of your day and being interested in, I guess, issues which are central to all of us in mental health, or that's what I will argue, that early intervention, getting in as early as we can to give families and infants the best possible start to developing their resilience, their strength and capacity to manage the inevitable stresses of life, and to give them that head start to having positive mental health. This, to me, I think is one of the very important questions that faces mental health and governments and all of us as we want to improve outcomes, reduce rates of mental ill health and disorder across our community, and importantly, to protect children's development as best we can. So I'm coming at it from that sort of framework, and it's an area that, as I'll describe, we've, with a lot of support from Professor Tonge, which has been much appreciated. This is one of these very long projects, but it's a central issue for all of us. And we've been building our thinking in this whole area of how early should we intervene, the importance of the early childhood developmental period, and how do we best advocate for the sorts of services that will really support vulnerable families across our communities and really support them in doing the job that all parents want to do, which is to give their child the best possible start. Next slide, thanks. So I'm talking about very little babies. So the infants, just so you're aware that we're working with in this program, which is a group program for parents and infants, as young as 4 weeks of age. In some situations, we already know parents to be because we've met them during pregnancy, because many people who are anxious or presenting with stress related to becoming a parent will seek some counselling or support during that period, and that's very important to know. And then we've been working on these interventions for someone as young as this little baby who's a very nice, healthy baby who we worked with for some time. Next slide, thank you. So infancy and early relationships, why are they so important? For lots of reasons, and some of this you might have heard about, that From a scientific point of view, people very much currently think about what goes on during the first 3 to 4 years of life as absolutely setting the foundations for later emotional and psychological health. So the beginnings of emotional and good mental health are in this infant period. Infancy is a critical period, and what that means is certain things are needed to really get that healthy development underway. And that sets the child up for having more positive development across their lifespan. So what do babies need? And why is it sometimes difficult to provide that for them? Babies essentially need caretaking relationships, people who are there for them, who help babies deal with the challenges of being a baby, the things that babies have not yet developed, dealing with when they get upset, with their feelings, learning how to signal what they need to other people. So some of the basics that babies can struggle with really do respond to having parents who can be available and who have that capacity to sit with the baby and help babies develop their own capacities. That's really crucial. And there are lots of factors that can influence that and support that, but there are also factors that impact those relationships around a baby. So we think about babies as not being by themselves. In fact, they need available and supportive care. And there's a very famous quote from someone who worked intensively with infants and parents, Winnicott, who said, "There is no such thing as an infant." Now, he clearly didn't mean that there are no such thing as babies, but he meant there are no such things as normally happily developing babies by themselves. So social development is very important. And worthwhile remembering, I think, that at the moment, in the middle of this pandemic with social isolation, particularly for people living here in Victoria at the moment, though things are improving, thank goodness, we have a lot of vulnerable parents with young babies who have not been able to access the usual supports that in most communities have been available for babies. So parent support, mother-baby groups, visiting professionals, early childhood workers. A lot of this is being done as best as possible via distance, and that's been very important. And significantly, parents might not have access to friends, extended family members and others who would be available to help with that transition to becoming a parent, particularly for parents for whom this is the first time. So we're living in a very different environment, quite a high risk period. And so there's, at least in surveys that have been done, increased rates of stress in early parenting. And that's something that we have been working to try and support with. Next one, thanks. So this area sometimes is called early in life intervention. Early intervention is sometimes used to talk about youth or adolescent intervention. The way I'm talking about it, it's very much intervention at the beginning of development, which we hope is preventive intervention, in that we're giving infants a good start to psychological development. We're looking at their overall development and helping them develop attachment relationships with people who are there for them, that help them feel securely attached, as sometimes it's called. But infants need to know who is actually there for them, and to have relationships that are consistent and available. So this sort of early in life intervention really means working both with infants and helping them with their experience, but with parents, caregivers, extended family, whoever is important for that baby and involved in care of that baby. That will vary from cultural group to cultural group. And look, sadly, we have, at least in Australia, big cities, a proportion of parents who are trying to parent alone, who might be very unsupported, who don't necessarily have a wide social network, cultural group, or extended family members. So that makes it a difficult task for them. But the idea is, in this sort of work, that we try and support whole communities who want to provide their young and their infants with the best possible outcomes. Our work is aimed at developing better approaches and new models about how we actually provide this support. We think that it needs to be obviously accessible so that people don't have to travel into major metropolitan areas, let alone into hospitals. We would ideally like to see these programs rolled out in people's communities as part of a community health approach, involving local practitioners so that local families and people who need this support know where to go, that they can actually go there. And there's some great models around of how to do that. As usual, we need to advocate for more support for that. We need approaches that are family supportive, that acknowledge the needs of different families, whether that's cultural variation, or particularly if they might have an infant who needs particular input. So a baby who might have developmental issues, or babies who for whatever reasons might be challenging for many parents. Next slide, thanks. So the sorts of interventions, and I'm going to say just a little bit about this, so that we can all have a sense of how we run these sorts of programs. We look at infants and their environment, the relationships around them, and how that early interaction actually goes. So in a simple way, we're interested in helping parents know how babies communicate. So babies are pretty good at trying to tell us when they're feeling upset, frightened, and parents can find that more or less challenging, but learn, if things go well and they're supported over time, how best to respond to their baby. So we want to really work on those relationships, helping attachment relationships that allow the infant to feel secure. Someone is there for me, and it could be several people. There can be many attachment figures, not just the one. That the care and responses they get are on the whole, can help them with any anxiety or fear or negative emotions when babies don't have all that capacity to sit with that alone, and relationships that are consistent and available. The methods that we use are actually having parents or caregivers together with their babies, and a clinician or an infant mental health worker will actually be there. So we don't separate babies and from parents. We work at building up skills in reading babies, looking at babies, and together with a parent or a carer, we'll help them put some words to that and try and understand how their particular baby communicates. Now, all babies are different. All babies have their own particular style of communication, and parents need to be the expert in that. So it's very important that clinicians don't take that over and say, well, I know exactly what's going on with your baby, so I'll tell you, if you follow my instructions, everything will be all right. But we're building up people's confidence that they can be the one who has something very important to offer their baby, and that their baby actually looks to them. The baby knows who their person or people are, and that's what's going to give them that resilience or strength to deal with stress going forward. Next, thanks. This is just a nice painting, America Sap painting of what you might call a nice interaction between a happy mother and a baby. In an idealised sort of world, all interactions like that. In the real world, parents can suffer from a range of stresses. They can be tired. They can be overwhelmed by the challenges of being with a child, particularly if they're isolated or have other issues. Some parents might be experiencing depression and anxiety, a whole range of issues that can actually interfere with this nice interaction where this mother and child are looking at each other, obviously very closely bonded. We're trying in our work to build up those moments, which for some parents sadly might be few and far between, but to give some pleasure in relationships, to help infants feel happy that they have someone who's there for them. Next, thanks. So the vulnerabilities that we work with, I think we're all familiar with the stresses that are perfectly normal and common for all new parents. But some people are really very overwhelmed at times by feeling anxious and having a lack of confidence. They might need that support in understanding baby's communication. How does a baby tell me what's going on? A particularly vulnerable group who we see often in mental health services might be parents and carers who themselves have had significant early disruption of care. And by that I mean they might have had changing carers, they might have had periods where carers were either absent or unavailable, a whole range of scenarios. Some people sadly might have experienced more traumatic relationships and interaction with their own parents who weren't coping. When they come to parent, these are individuals who really want to get it right, who really want their infant not to experience some of the negative things that they might have experienced, but they find that very challenging. So that makes them feel very anxious. And many parents can actually describe that very well. They're very aware of that. It's quite a painful experience. I really want to parent my child in a way that they don't experience what I experienced, but I'm scared that under stress, I might not have the capacity to deal with my own feelings. They might be feeling irritable or anxious. So working with those sorts of risk factors is part of the work for people in that category. And again, the aim is the same, building up people's sense of competence as a parent, giving them a sense that they can do it, and some strategies for dealing with their own anxiety and feelings if those are difficult for them. So there's a range of stories that we have to be able to respond to, but in the middle of all of this is the relationship with the baby. So no matter what the story and what the vulnerabilities might be, our approaches are to build up how relationships function and to help parents who are otherwise stressed or vulnerable to focus on infant development and developmental support. Next, thanks. So BEAR, as it's called, stands for Building Early Attachment and Resilience. And this has been one of these really rewarding projects to be involved with, where a group of people and organisations really focused on mental health and the interests of children have got together, and we've been very fortunate in the support that our group at the university have had from Mental Health Foundation, and also I should acknowledge our funding support, philanthropic funding from both the Pratt Foundation and Liptember, which has been crucial to actually developing a program that can really focus on developing a workforce that is more skilled in and competent in thinking about early interaction. There's a lot of interest in doing the work, but unfortunately in the majority of training programs, there's not been that much focus on how do you actually interact with and look at a baby who's 2 months of age and understand if they've got difficulties, and how do we talk to new parents about what they can do. So we've developed a program which is a manualised program. It's a group program for mothers, fathers and others, very open to whoever the significant persons are in the life of a baby. And we've been looking at various changes that we might need to make to a program for specific groups. And I'll say a little bit about that. Next, thanks. This is our original BEAR mascot, who is our research coordinator's grandson. Very nice boy. He's now, I think, 5 years of age and doing nicely, surrounded by bears, and courtesy of a friend of Professor Tonge, who has donated many bears, and the babies gravitate towards them, their beautiful colours. And so that's become our signature picture. Next one, thanks. So we aim, just to summarise, to build resilience. How do we help babies and young children and their families to learn to manage the stress of life? And this is really seen as the basis of managing adversity, which we all need, particularly in the current times. We think that we are protecting emotional and mental health, and it would be really good to know if we can ever do those sort of long-term studies to get more evidence that intervening very early actually is protective. There's some evidence to that effect, and it'd be really good to build on that. That's a central point when we come to trying to get governments, funders and others and services to pay attention to this sort of work maybe more closely and be more supportive. That's a central argument that if we intervene earlier, if we provide that healthy start to emotional and psychological life, we should impact on rates of community mental health. That's what we want to argue, but it's very difficult to talk about something that might not be easily demonstrated until several years have passed, if not decades. We need to reduce parenting stress as part of that process. And as I said, identifying and addressing all those issues. So the aim of early intervention is early identification. So we like, if we can, depending on where we're working, to be able to help clinicians identify women and families during pregnancy who might have particular vulnerabilities. So for example, in maternity hospitals at the moment, there is more focus on screening and identifying parents who have histories of mental health issues such as depression, those who might have specific issues with substance use, and for, importantly, women and others who are living in environments characterised by violence and conflict. That's important, obviously, for women during pregnancy, but it's also hugely important to think about child protection needs of infants who might be born into relationships where there's high rates of conflict and other difficulties. Next, thanks. So BEAR program works with these relationships, and the science is showing us just how important the quality of early interaction is in terms of brain development. So this is pretty basic, that babies' brains grow better in the context of positive relationships. Next slide, thanks. We look at a whole range of different scenarios, as I hope I've stressed to you. There are many stories here, and we are developing a series of programs which all have this particular focus. So we are doing, so you're aware, similar models in pregnancy. We have our group program for parents and infants, and we're developing programs for what we're calling groups with specific needs. One example of that will be the drug and alcohol using women attending specialist services, often in maternity settings. Very important to think about supporting people with those sorts of difficulties who, on the whole, are very much trying to get drug use under control during pregnancy, but might have specific issues that might make parenting challenging for them. So our programs, by definition, are multidisciplinary. We are not only focusing on highly trained specialist mental health practitioners, although we have an important role in this, but it's very important that all professionals and workers across our communities who come in touch with early childhood issues and new families have those skills. So a particularly important workforce that we work with are maternal child health nursing in the Victorian context, who are a home, have been until recently, home visiting service, but a very supportive group run at a local government or community area, very much trusted and by local communities, doing a mixture of baby checks, so baby developmental checks, but also support for parents, and some lovely work helping parents learn better how to interact with babies. They also can identify and pick up mothers who might be experiencing things like postnatal depression, and better identifying those who might need support. Primary care, whether that's general practice or other health workers, also have a really crucial role. Child protection agencies and staff are also a group that who offer a lot of support for very vulnerable families, would probably think about incorporating some of these approaches into their work. So it is actually very broad. We run training programs which are very, again, open in terms of discipline, and have been well attended. Next one, thanks. Okay, so the groups are targeted at people who are coming from the vulnerability groups. We're usually seeing infants within that range. We can start as early as 1 month of age. And we've done that mainly in what we call Bare House, which is a day program version for those families very much at risk who are leaving hospitals with very little in the way of support. And it was felt that getting in touch with them early, linking them into an early intervention was very helpful. At the moment, because of our restrictions and the pandemic, we've been offering our programs via Zoom, via video conferencing, which has been remarkably acceptable to families. Now, whether that's because there's very little else, or if it is actually going to be able to be seen as really supportive going forward, is what we're investigating at the moment. And so we will be publishing the results of that. But so far, parents would rather have the use of the technology once they're accustomed to it than have nothing other than a phone call. Though interestingly, the babies are much easier, seemingly find it much easier than the adults to adapt to a screen. Babies come to know us through sight. They are responsive when we talk to them and interact with them. They also get to see and meet their peers. And it's important to recognise that some of these babies have not had another baby that they've seen in their little lives. So hugely important. And they're very pleased about that. They light up when they can do that. So we usually work with around 5 to 6 dyads. The full length program was for 10 weekly sessions. We then have included sessions specifically for fathers, partners, or whoever's there in a family or social group involved in face-to-face interaction with the baby, with very positive uptake. And there's interest in running a father's program for particularly for fathers who are experiencing stress and anxiety. And as we know, fathers also find transition to parenting very challenging, as we should expect, and having something specifically for fathers would be important. We're running a version of our program in neonatal intensive care at one of the major hospitals, which will be using the program specifically for fathers who've been struggling with the stress and challenges of having sometimes quite unwell babies, and juggling their roles and developing their role as a father, but also the issues about supporting partners in that situation. Next, thanks. So BEAR looks at trauma, as I've mentioned, and how that can affect the way a parent thinks about their baby. We work on developing what's called affective competence or emotional resilience. Parents need sometimes support in how to deal with babies who get into very negative states, which babies do. Babies need support from a parent who can be there to help them tone down their negative state. And so we do some literal coaching about baby distress and what to do with baby distress, trying to help parents feel more confident as an attachment figure. We help parents think about what's going on in the inside of a baby. What could a baby need from them so that they can feel more confident in that role? And it might be very simple things. But I had one woman who said to me after she'd participated that the best thing she learned was that she had something to offer her baby, whereas when she first had the baby, she had no idea of what that might be or that she was going to be good enough. And that's a really very important statement for her to be able to make. So really being supportive, being non-judgmental, and building up those sorts of skills. Next, thanks. Next, thanks. All right, so developing reflection, coaching about emotional interaction, and helping parents who've had early adversity themselves understand the ways in which they might be able to change that so that they don't necessarily have to repeat things that were difficult for them in their relationship with their baby. And that's a major theme that we support parents with. Next, thanks. So dealing with someone of this age is crucial, and it is at the level of emotions. So babies move, like this little one does, through various states very, very quickly. And the job of a parent, and this is the coaching part that we do, is to help us understand what might those facial expressions mean. We could all pick one and try and put a single word to what feeling that baby has. It's quite an interesting exercise. And there's no right or wrong. There are many options here. And parenting is sometimes about that, the wondering about what's going on. If a baby's upset, wondering what the baby might be upset about. If a baby is happy or looking surprised or interested, trying to talk with them about that. So we are literally coaching emotional interaction. So looking, reading, and putting words to what the baby might be experiencing, and then handing it back to the baby, talking to babies about feelings. Next, thanks. So the diverse groups I think I mentioned. We have all these other groups who are very important being trialled at the moment. We've finished a trial with the substance abusing mothers who used this sort of approach really well, which I think is important to acknowledge, that the stereotypes that are sometimes held about these women as mothers were not held up, which is important. We're very interested in issues of family violence and women who are in emotionally abusive situations with an infant, which is clearly a child protection matter, but also one that needs some support as people are making decisions about the future of themselves and their babies. Next one, thanks. So we're collecting the evidence about this. The principles behind BEAR programs are basic principles of attachment and interaction. We've stuck to those, and I think that's made it broadly applicable to many groups in the community. And we have to acknowledge that within services at the moment, there are very limited services that target particularly vulnerable groups. We have a lot of maybe a child protection risk assessment framework. We have legal frameworks. There's little therapeutic. So one of the issues is, how do we advocate and how do we link this and create a priority, as there's a big Royal Commission going on into mental health services, as we're all aware. And so several of us were involved in giving evidence along these lines. We'll wait and see what happens next. Next, thanks. We want these sorts of babies, I guess, is the bottom line. And this is a healthy, very healthy baby. He's a nice, one of our control babies. Twinkling eyes, alert, interested, happy. At times he's unhappy, but he comes from that sort of very healthy, good beginning, which is absolutely essential. And lastly, to end and then see what questions. Next one, thanks. Advocacy, as I've said a couple of times, is really getting the messaging out there, being able to say that a healthy start to emotional life begins in infancy, not later. We don't suddenly learn how to be emotionally healthy when we're in adolescence, unfortunately. It starts much earlier. That development in infancy sets the stage for later mental health and resilience. We need to really hammer that message, I think. It's tiring to have to keep saying these things for a long time, but if that's what it takes, that's what we should do. We should use the term early in life intervention and really let mental health services and other people in the field and health services know that there are approaches that will support development, that are ultimately about preventing mental disorder. And the other important thing is that we want to make this a normal part of early family development by having approaches that are based in communities, that are multidisciplinary, that use the skills of so many in our health and welfare and child sector who are out there and are trusted workforce, and really involve them, particularly as government's looking at more local services and ways of creating early childhood hubs. So there are lots of different models being discussed at the moment. And importantly for all of us in this area, building on the evidence. We need more research. We need better evidence about what we are actually doing, which we're all very committed to. So thank you for listening. That's a quick overview of the BEAR model, and I hope that raised your interest in getting in early. Thank you.